This is internal medicine. 10 stations, and that's the first station. This patient has presented with a complaint of fever and general body pains. What does this test show? Mhm. Now let me hear from what we have to say. What does the test show? Now people don't want to speak. Yes, Purity. Okay. Ah, sure, Palichung. Okay, that's good. That's good. Very good. Okay, would have clapped for you, but you're not here. So this slide is showing the trophozoite stage. Remember when a mosquito bites you, it will release the sporozoites. All right. Those uh, sporozoites are going to transform. Okay, they are going to transform to become the merozoites, and then the schizons. The schizons can further, because schizons are like these big structures where inside you have got merozoites, so they can further break to release the merozoites. Those merozoites will start to grow in blood. Okay, and then another stage that you are going to have a trophozoite. So when the sporozoites have been released, they are going to go through these stages from the sporozoite. They will become these trophozoites. Now the trophozoites, you need to know there are two. You have got the immature ones and the mature ones. The immature trophozoites are, let me start with the mature ones. The mature ones are really more the same in all the species. The immature ones are going to be a bit of more species specific. The immature trophozoites, we also call them the ring form. Okay, the ring form of the trophozoite, that's the immature. They look like headphones if you look at them, or they look like a ring. Those headsets you put on you when you are moving in the streets. So that's the ring form of the trophozoite for Plasmodium. So what is the diagnosis? What will be the answer for that? What is the diagnosis? It's the same thing we've been saying. Let's speak. Mhm. Okay, this is malaria. Okay, great. Name five species for the causative organism. What are the five species? Okay, excellent. So, Falciparum, Vivax, Ovale, Nolensi, and Malaria. Name the three stages of the life cycle. So, what are the three stages of the life cycle for Plasmodium? Uh huh. Sporogon. Okay. Okay, that's not bad. Now, the life cycle of mosquito, I mean of malaria parasite, which is Plasmodium, is divided into what is happening in the mosquito. So I've got the mosquito cycle and then the human cycle. Okay. In the mosquito, the life cycle in a mosquito. Remember, the mosquito is the definitive host. What happens there is known as sporogony, formation of the sporozoites. What will happen in the human being is the formation of the schizons. So we call that as zygony. Okay, that's the asexual, because humans are the intermediate host. Now, in humans, you have what is happening in the liver and what is happening in blood. So, in blood, that is erythrocytic zygony. And then what is happening in the liver, that is exo, because outside the red blood cells. So, exoerythrocytic zygony. We are calling both of them as organ in the liver and also in the blood because they are literally going through the same stages. When the sporozoites are released, the first place where they go, like within 30 minutes, will be the liver. They'll be compared to the trophozoites. The trophozoites where you have got the early and or the immature and the mature one. The early, which is the immature, is the ring form which you see in blood. And then you are going to have the trophozoites being converted into schizons. Schizons are going to grow and then they will rupture, releasing a lot of merozoites. That is in the liver, and then those merozoites will enter into the red blood cells. Okay, and then the process will happen also in the red blood cells because the first thing what was happening was in the liver. These merozoites can actually further convert, okay, into the microgametocytes and macrogametocytes, which can convert into the micro and macro gametes, which are going to fertilize each other to form a zygote, which produces a ookinete, and then oocyst, and then sporozoid. This is happening in the mosquito because the mosquito will actually take up the microgametocytes and then the macrogametocytes after a blood meal to undergo sporogony. Okay, so you have got those three. So list five complications of this condition. Any complication for malaria? AKI, anemia, outbreak, pulmonary edema, and cerebral malaria. Okay, very good. So malaria, you have got two forms. We have what we call uncomplicated malaria and the complicated malaria, which is also known as severe malaria. I don't know which rotation is your next. Is it obs and gyn? Yes. Okay, you're gonna find pediatrics. There's always the severe malaria is one of those important topics you need to know. You need to know the 10 parameters for severe malaria with the values. Okay, those are the complications via a lot, including cerebral malaria, severe anemia. It is really severe, like you see the HB is less than 5. Hypoglycemia, you see that the glucose is less than 3 millimoles per deciliter. It's really, really decreased. And then acute renal failure, pulmonary edema, there's going to be metabolic acidosis. Okay, someone will literally be having convulsions. The GCS score is going to be so decreased. For children, the Blantyre score is going to be so decreased, and you'll be expected to know just those values. Then name any three drugs used to treat this condition. What drugs can you use to treat malaria? Any three. This was an open question. Mm-hmm. Lumefantrine, okay, quinine, chloroquine, mefloquine, all those. Okay, station 2 is this one. The patient is being followed up for joint pain and a skin rash. Describe the important sign in the picture. What's the sign here? Malarash. Good. Okay. What is the diagnosis? SLE, systemic lupus erythematosus. Okay, excellent. Systemic lupus erythematosus. So never write abbreviations. List five other clinical manifestation of this condition. Any manifestations for SLE? A discoid rat. Okay, that would be when you are because lupus itself has got types. Systemic lupus is just the commonest form of lupus, and then you have got also discoid lupus. Okay, it's also a type of lupus. So now the clinical manifestations. Uh huh. Joint pains, lupus nephritis. Okay, good. Anything more? For lupus, you need to know it literally affects every system in the human body. Every system. And what is the commonest system affected? Not really. And that's a question for your theory. Okay, for your theory. Yes? The the musculoskeletal, very, very important. Okay, it's a commonest. So there's going to be arthritis. It's actually when you in Unity 5 topics, one of the important topics you discuss is that's actually rheumatology. You discuss arthritis and for arthritis you divide it into the seropositive and the seronegative. And this is one of the diseases that you actually discuss under arthritis. Very important. This guy can actually also result also in infective endocarditis. Now, endocarditis due to systemic lupus erythematosus is known as what? Excellent. Liebman-Sachs endocarditis. Okay, you have got many other complications, literally on every system. There will be a renal nephropathy, proteinuria. There's going to be nasopharyngeal ulcers, photosensitivity, arthralgia, arthritis, neurological manifestation like seizure, psychosis, hematological abnormalities to basically lead to a pancytopenia also. Briefly outline the list any five important investigations. Any investigation that you can carry out in lupus? Okay, so basically you are going to, because systemic lupus is is an autoimmune disease, meaning the body is producing antibodies against the components of the human. So you are going to have antibodies against the nucleus, that is the nuclear antibodies, and then we're going to have the anti-Smith antibodies, we're going to have the anti-DNA, double-stranded DNA antibodies, literally antibodies against the different components. Okay, you can also do analysis because remember we said that there's going to be injury to the kidney and the nephropathy, and then you can also look at the complement system, specifically C3 and C4, which are going to be lowering. Look at also just the other organs that have been involved. For example, you expect that this patient might actually have arthritis. So, what investigation do you think we can? Anyway, arthritis is very important. There's a certain paper. It was the end of rotation. It's like they just brought it. The paper was just on arthritis. You even wonder who prepared that paper. I think they just gave someone from Unit 5. It was just arthritis, arthritis, arthritis. So you need to know arthritis also. So you can do renal function tests, kidney function, the kidney, those are the kidney function tests, liver function tests, because there are many different complications. For all those complications, you just want to see if they've been, that organ has been involved. So you will do investigation depending on that. And then briefly describe or outline the diagnostic criteria. Anyone who can tell us about the diagnostic criteria for lupus? Anyone? So for the diagnostic criteria, there are 11 features that you need to know. And then of the 11 features, if you have got any four of those features, then you are going to diagnose lupus. It is a diagnosis based on what we call the American College of Rheumatology. So that includes a malar rash, a discoid rash, photosensitivity, oral ulcer, arthritis. Take note that this arthritis is swelling of two or more joints. Okay, but this, please, you need to know again, this is a non-erosive arthritis. The joints, the bones around the joints are not destroyed. It's non-erosive. You find that in the exam paper. And then there's also serositis, which is basically inflammation of the linings in the body, kidney disorder, neurological disorder, blood disorders, which is a pancytopenia, immunological disorders where you find the anti-DNA and Smith and positive antiphospholipid antibodies, and then also abnormal anti-nuclear antibodies. So ANA is alone. The other antibodies have been put together like that, you can see. So if you have got any four of these or more, that will diagnose this condition. Okay. I want you to take note that anti-double stranded DNA is specific for SLE. It is specific for SLE. And you just need to look at which one is specific, which one is sensitive, which one, when you see it, is definitely going to mean that you have got SLE. But sometimes you barely see it. Okay, station 3. The other question was talking about management. So for the treatment, basically you want to look at the complications. Like give painkillers for pain, corticosteroids to reduce all the inflammation because the body is actually hyperactive. That's what is causing problems. The body is producing antibodies to fight against yourself. Okay, so very important. And then immunosuppressants. You can also give antibodies against the antibodies that the body is producing. So those are the biologics. Antibodies against the antibodies. The next session is saying the 25-year-old man presents with a 4 weeks history of a productive cough, fever, night sweats, and weight loss. What does this X-ray show? Anyone? What can you see on the X-ray? Okay, not really TB, but this is a miliary picture. Okay, not TB, but picture. All right, because you have got many differentials or many possible causes for a miliary picture. And you need to know the infectious causes, the non-infectious causes for a miliary picture. Miliary TB is just one example. It is basically tertiary TB, okay, or disseminated TB, the TB that has spread. So list five differentials. Now that's where you are mentioning the possibilities. Let's mention. The first one you've mentioned. One possible cause of a miliary picture is TB. Any other? So specifically, it is it disseminated TB. Any other? Histoplasmosis. Any other? Yes, blastomycosis. Any other? Yeah. So basically, the opportunistic infections caused by fungi, most of them are caused by fungi in someone that has HIV. We'll show this picture. Okay, coccidiomycosis. Anything else? Anything else? Okay, that one is a worm. Really not. Yeah, that one is a worm. So you will see the worm moving, but yeah, not much, not really. I think it's like aspergillosis. Okay, aspergillosis. Other things besides these fungal infections, bronchiectasis for lung disease, lung abscess, even cancers. Okay, like this cavitating squamous cell carcinoma. Please also know the non-infectious causes. Okay, what is the most likely diagnosis? So in this case, the patient has got 4 weeks history of productive cough, fever, night sweats, and weight loss. So what would be the most likely diagnosis? Very good. That's a miliary TB. And then list five clinical signs you might elicit. Someone that has TB. Always, when they ask you a question like that, think of inspection, palpation, percussion, and auscultation. So, what are the possible findings you are going to have on inspection, percussion, palpation, and auscultation? Any five signs you look for? Someone with TB. Oh, we don't know TB well. Which is the commonest the condition, especially if we are in Unity 3, isn't it? So things like acacia, people with TB have got really weight loss, okay? A lot of wasting, fever and tachycardia. You can pick caucasia just on inspection. The tachycardia will pick on auscultation. And then there is the fever. Of course, you feel when you are touching the patient. And then when you're auscultating again, inspiratory crackles over the affected area. And then these guys can actually have finger clubbing, yeah, if it's a chronic disease. And then because you have got TB, really is an infection, you can have signs of pleural effusion. Okay. Remember, for pleural effusion, you can classify it, and that's one condition you need to know: exudative and transudative. Specifically for the exudative, you have got infections, and TB can be one of those causes. Name any two diagnostic tests. Any test that you can carry out to diagnose the condition? Okay, very good. Besides that, anything else? Sputum culture, gene expert, urine lamb, anything else? Okay, that one it will be an important investigation, not really for diagnosis. Okay, not really for diagnosis. And you can do a Mantox skin test. Okay, and then for the gene expert, what do you use when you want to carry? What specimen do you get for gene expert? Anyone? So gene expert, you can get urine, you can get sputum, you can get different fluids, CSF and such, like in as in this TB of that is affecting central nervous system. Gene expert is important in that it will not only show you the bacteria, Mycobacterium tuberculosis, it also shows you resistance to one of the drugs for the treatment of TB, which is anyone? Rifampicin. Okay. Please make sure that you know what are the side effects for the four major drugs of treatment of in the treatment of TB. Name any three drugs used. Okay. Rifampicin number one. Any other two or three? Isoniazid. Uh-huh. Okay, very good. Ethambutol and which other one? Isoniazid, rifampicin, ethambutol, pyrazinamide. Okay. Please know the side effects for those. Yes, please. Okay. Please know the side effects. And why do we use pyridoxine when you are treating people with TB? Know that. Okay. The next question, the male patient presents with epistaxis and left knee swelling. What is the diagnosis? Anyone? This one we don't know. Okay. They present with epistaxis. If you hear epistaxis, sorry? Okay, we are what would you say? Okay. Oh, hemophilia. Okay, the correct answer is hemophilia. Okay. In hemophilia, what happens is that someone is lacking clotting factor, so they easily bleed. And the bleeding, you see that the bleeding is mostly going to be into joints. The bleeding into joints. Okay. That's what you're going to do. And this is a bleeding in the joint that you can see here. So the joint is going to be swelled. That's why there's also epistaxis here because someone doesn't have a clotting factor, so they can easily bleed. So that's the most likely diagnosis. Hemophilia. Don't even classify it. What is the mode of inheritance? How is hemophilia transmitted? Okay, excellent. X-linked recessive disorder. Okay. So what does that mean? Between males and females who are likely to have hemophilia? Males, and it's for a reason why. In other words, for a male, there's no possibility of being a carrier. You're either sick or you're normal. So for females, they can be carriers and escape. Okay. Name two clinical forms of this condition. So that's why I mentioned there's hemophilia A, there's hemophilia B, there's actually also hemophilia C. Hemophilia A is because of deficit in which clotting factor? Okay, good. And then B, factor 9, excellent. And then C is factor 11, right? List five important diagnostic tests. So, what tests can you order in a patient that has got hemophilia? Okay. Now, so specifically for APTT and PT, which one do you expect to be abnormal? Why? Why APTT and not PT? Excellent. So remember the intrinsic cascade starts with 12 activated to 12A, which activates 11 to 11A, 11A will activate 9 to 9A, 9A will activate 8 to 8A, and then 8A will activate 10 to 10A. That is intrinsic. So all the factors that are possible in hemophilia are actually found in the intrinsic pathway. And that's where that's what APTT measures, the activated partial thromboplast in time. The PT will only measure the extrinsic pathway where I've got factor 3, factor 7, and of course the common pathway basically starts from factor 10, and then you have got clotting factor 5, okay, and calcium, and then activated factor 10 is going to convert prothrombin into thrombin, which converts now fibrinogen into fibrin, which forms a mesh. And please take note that that mesh that you form is actually what stops the bleeding. Okay, that mesh. Now you have got a guy which we call plasmin. Plasmin is a cis. Okay, so plasminogen can actually be converted to plasmin, which is a cis, which will begin to break down those clots. So in people that have got DVT or PE, pulmonary embolism, what happens is that those clots are going to be broken down by plasmin. And what happens in that case? You are going to see a lot of breakdown products of the clot. And the commonest one is the D dimer. It's a breakdown product. So if you see a lot of D dimers, it means that this person had the condition in which they were having their blood clotting, like DVT, PE. That's how you diagnose those conditions. So always order for the D dimers. Okay, very important to make sure that you just know that. And so for you to convert plasminogen to plasmin, there are some things that promote that. For example, we have got the tissue plasminogen activator, TPA, and urokinase plasminogen activator, which is actually produced by strep, okay, the bacteria. So those can actually activate plasmin to start breaking down clots. So there will be easy bleeding because we are breaking down clots. Okay, so those are some of the investigations that you can actually get to order APTT, PT, bleeding time also, which is PT and bleeding time is usually normal. Okay, CBC, complete blood count, just to look at also the platelets, the white blood cells, and the red blood cells to just find what's really wrong here and which cell lines are decreasing. And also of important is the factor assay, especially factor 8 and 9. You can also do 11, but 8 and 9 are the commonest. Okay. Name one other inherited bleeding disorder. Any other that you know? Okay, the von Willebrand disease. Any other? Mention that again. Okay, I've never heard of that one. Let's believe that it's there, but I've not heard of it. Have we heard of the antiphospholipid syndrome? Okay, and it's very important, especially in the pregnant women. And then list any five acquired bleeding disorders. Anything that is acquired that you can mention that can cause bleeding. Yeah, you're not born with it like that. Okay, a liver disease, and specifically because the liver will produce what? The clotting factors, isn't it? So someone will be able to bleed. Any other? Okay, very good. So the thrombotic, thrombocytopenic purpura, the immune thrombocytopenic, you have got also HUS. Those can actually cause bleeding. Okay. And of importance is anything that is acquired that you are not really born with. Also, things like GI problems, all right, where you are not absorbing proteins. If you can't absorb proteins, remember it's from actually these proteins that you also have these clotting factors, and also problems with the kidneys, because the kidney can actually end up losing these clotting factors, like in kidney disease. So they'll be losing the clotting factors, and what does that cause? That can cause you to actually bleed, including malaria. Malaria causes kidney injury. Because of that kidney injury, there's going to be a loss of proteins in urine, including the clotting factors, and so you are going to be bleeding. So how is this condition treated? The best thing that you want to do for the patient is replace the factor that has been lost. Factor replacement, very, very important. Okay. And then manage the pain, because those joints are going to be painful a lot. Actually, they are also our colleagues. It should be a multidisciplinary team. The physiotherapists, they are going to come in with what we call the rice therapy. Those are the physiotherapists. So rice, the R there is to rest. Start resting the limb. They'll put ice on the wound, and then they'll compress it and then elevate it, and that is gonna help the patient. Okay. So physios are very important. There's another drug, desmopressin, very, very important drug. This one basically stimulates the release of factor 8, desmopressin. Okay, station 5 says that this patient has presented with lower limb swelling and shortness of breath, waist when lying flat. Admitting doctor notes patient has abnormal neck palpitations equals dancing carotid. What is the full diagnosis? So remember, swelling, lower limb swelling, shortness of breath when lying flat, and then there's a dancing carotid. So what is the full diagnosis in this case? And then look at the X-ray also. What do you think? What is the dancing carotid code? Okay, thank you so much. Aortic regurgitation. Okay, before we can even comment on that, dancing carotid. What is the term? What's a sign? Corrigan sign. Okay. So this is likely aortic regurgitation. But remember, the dancing carotid is pointing you to aortic uh, regurgitation. But then you have got other features like the limb swelling that is pointing you to heart failure. So the full diagnosis will be aortic regurgitation with congestive heart failure. Okay. Congestive heart failure. Normal, this term congestive in clinical practice is trying to use it little, because you should mention what do you mean by congestive. Congestive just means that you have actually fluid accumulating in the lungs, and that causes difficulties in breathing. So we want to say biventricular heart failure instead of saying congestive. So either say left-sided, right-sided, or biventricular heart failure. So dancing carotid, Orthop notices the difficulties in breathing when lying flat. Peripheral edema. There's also a cardiomegaly that is going to be pointing you to heart failure, but dancing carotid will be pointing to aortic regurgitation. So, them five important signs you might elicit in this patient. So, it shouldn't be hard for you to elicit signs in a patient that has got heart failure. Let's mention them. Any signs you can elicit? Okay, Demoset sign. What does a Demoset sign point you to? Okay, Demoset sign, aortic regurgitation. Any other? Quincke sign. Okay, any other? The molar sign. Okay, any other? Let's hope you know the signs you're mentioning. Okay, so you're going to have also a wide pulse pressure, and then the apex heartbeat, when you are trying to feel it, you might find that it's actually displaced. And then you can also find a murmur, that is early diastolic, when the heart is actually relaxing. best head on the left sternal edge when the patient is leaning forward and then they're breathing out. Quenk sign. There are also some signs which you've not read on in your rubric. Durosier's sign, which is a systolic and diastolic murmur head over the femoral artery when compressed. In case you can't remember the name, just mention the statement. Austin Flint murmur, a diastolic murmur head at the apex because of the regurgitant jet vibrating on the mitral valve leaflet. The Mosets, there is also the Trabear sign, which is a pistol short sound head over the femoral artery. So these are signs who point to regurgitation. Name three possible causes of this condition. Okay, what can cause problems with heart valves? So we call them valvular heart diseases, and this, of course, valvular heart diseases can lead to heart failure. So any cause. So by far, you need to understand rheumatic heart disease. You need to understand it. Okay, you need to understand the history, the natural history of rheumatic heart disease. How it starts just from a sore throat, and then so if someone has got a sore throat, you don't treat them, and of course it's common between 5 years and 15 years. If you don't treat it, 2 to 6 weeks later, it can actually go into rheumatic fever, and then if you don't treat it later on, 10 years, 20 years later, it can actually go into now the involvement of the heart. That would be rheumatic heart disease. Okay. So what criteria do you use for the diagnosis of rheumatic heart disease? The Jones criteria. Please, you need to know what components are part of the major criteria and which ones are part of the minor criteria. For the major criteria, you use the abbreviation SPACE, SPACE. What does SA stand for? The S, so subcutaneous nodules. The P, pancytopenia. The A, arthralgia. Specifically, it is polyarthralgia. It's or the it will be bilateral pain in the joints, and specifically the large joints. Please take note, large joints. And then so that's the A, and then C is the Sydenham's chorea, and then E at the end. What does the E point us to? Erythema marginata. Okay. And then the minor criteria, we are going to be looking at things like the PRI interval, the C-reactive protein. Okay, so those are the minor criteria. Another possible cause for aortic or the infective endocarditis. Which criteria do you use for infective endocarditis? Okay, yeah, the John Ducates or Duke's criteria. Again, you need to know the what falls in the major criteria and in the minor criteria, and how many do you need to make a diagnosis. You need to know for the which one is that, echocardiogram, which one is a gold standard for the diagnosis. Okay, please, you need to know. Okay, list the three important drugs used. Okay, any one other condition that can cause valvular heart disease. So you can also have connective tissue disorders, aortic dissection, connective tissue disorder like Marfan syndrome. There's also the Danlos condition, and then three drugs used to treat this condition. So for the drugs, just want to lose fluids because there's a lot of fluids accumulating in the lungs, in the body, causing the signs and symptoms. So diuretics, important vasodilators will also help because the heart is actually overworking to push blood against blood vessels that are small. So if you make the blood vessels big, it will reduce the workload on the heart. Digoxin, of course, is used in failure. Okay, so diagnostic investigations you can order includes an echocardiogram. You have got the transesophageal and then the transthoracic. Okay, An X-ray, like the one you can see there, an ECG to look at the hypertrophy of the ventricles, cardiac catheterization, cardiac, and then also some different blood tests that you can just order in case there is an infection. Remember, endocarditis is caused by infections, and you need to know the HAZEC group. You need to know which organisms are going to be common in what conditions. Someone that is an IV drug user, which type of endocarditis is going to be common. Remember, not only preparing for the OSCE but also for the theory. Okay. This man presented to adult medical emergency unit with altered mental state. What is the diagnosis? So, from what you can see, what do you think is the problem? Okay, like diabetes. Okay, what do you think you can see here? Okay. Have you ever seen a picture for Akanta the Niagara? Sorry. Okay, good. Okay, so please, I want you to go and look at the picture for the complication of diabetes, the Akanta. How am I trying to pronounce it? Acanthatosis nigrans. I want you to look at the picture. So this is dermatitis, okay? Inflammation of the skin, and you can see it's around the neck like that. When someone has got niacin deficiency, vitamin B3 deficiency, or vitamin B3 deficiency, okay, this is actually a condition known as pellagra. Pellagra. So the sign is known as a Cassor's necklace. It is a type of dermatitis around the neck, Cassor's necklace. So, what is the cause of this condition? We've already mentioned it's a deficiency of vitamin B3 niacin. What amino acid is associated? Vitamin B3. All right, that's basically the same thing there. Name the trad associated with this condition. So, what's a trad of pellagra? And what? And the last D? I'm not getting it. What are we saying? Dermatitis, dementia, and what? And I was hearing other things. And diarrhea. Okay, diarrhea. So sometimes it's actually a tetrad. So this patient will actually also die. So that's the four D's, including death. Okay. But now they are not dead. So dead. So you remove the death. So what is the treatment for this condition? Well, to treat the condition, give them what they lack. Okay? Give them the amino acid they lack. But now niacin, you will not give it direct. Instead, you can give tryptophan. Okay. Actually, here you can give niacin direct itself instead of tryptophan, where tryptophan is a precursor that you can synthesize niacin from. Now that's a pathway, and the patient really requires the 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 vitamin in this case. So niacin, vitamin B3. So the amino acid, what is the cause of this condition? There's a question, what amino acid is associated? Here, the amino acid specifically, it is tryptophan, because that is where vitamin B3 is, that's not an amino acid. Okay, that's a vitamin. So the amino acid is tryptophan. That's where the B3 comes from, the vitamin. The next question here, describe the abnormality in the image. What is the abnormality you can see here? Sorry? Okay, spoon shaped nail. So what is that called? Koilonychia. So what is your diagnosis? Iron deficiency. Good. Okay, iron deficiency. List the two other signs for this condition that you'd look for. For iron deficiency anemia, what other conditions can what other things can you look for? Okay, keratitis, stomatitis, anything else? Pala, okay, anything else? Pica. Okay, what is pica? So someone is craving for soil. Okay, so that one you actually that one you ask them in the exam, isn't it? I mean in the history instead of the exam. Anything else? Yeah, so the question is basically list two condition signs for or for this condition or for this, because yeah, true, anemia, there are different presentations, but then there are those that are specific to a cause. So that's why we started mentioning first those things that are specific to the cause in this case. Unless you've just run out of data, but mention those things that are specific. Right? Yeah. So besides that, the keratitis, stomatitis, pala, yes, it can be present in just like fatigue. It will be present in other features of anemia. Pica is not really specific to others. It's more to the iron deficiency. Okay. List four causes for the diagnosis. What can cause iron deficiency anemia? Anyone? Okay. Heme loss, like in what conditions? Yeah, PUD, and also menstrual bleeding. Okay. Especially those conditions where there's chronic bleeding. Acute bleeding, usually the anemia is going to be normocytic. Remember, iron deficiency anemia is microcytic. Okay, so where there's chronic blood loss, malabsorption, increased demand like those that are pregnant, chronic blood loss like PUD and menorrhea, poor data intake of the iron. Okay, and then list for diagnostic features, or what will be the diagnosis, what investigation that we're going to carry out. Mhm. Okay, the iron studies, please, you need to make sure that you mention the own studies, don't just state own studies. Okay, let's mention the own studies. Number one, ferritin. What are you going to be expecting iron deficiency? Okay, number two, besides ferritin, transferrin. Number three, total iron binding capacity. Number four, anything else? Okay, even the iron itself. So please make sure that you know the serum iron is going to be low. Total iron binding capacity is going to be raised. The proteins that bind iron are trying by all means to bind the little iron that is present in the body. So that's why the total iron binding capacity is actually increasing. Serum ferritin is going to be low. Ferritin is actually a store, okay, for iron. So it is going to be low because the iron stores have been depleted. And then there's also transferrin. Transferrin is actually a transporter, serum soluble transferrin receptors. And these receptors will start to increase, okay, so that you can actually bind as many iron as possible. So the serum soluble transferrin receptors will try to increase. Station 8, female 25 in the picture presents to the emergency room with raised blood pressure. What feature are of note on this picture? They have got raised blood pressure. What is of note on the picture? A swollen face. Okay. Anything else? Acne. Oh, this is what you call acne. It's not. Anyway, ladies understand very much. Even just come a little bite from a mosquito is acne for them. Okay. So, likely What would be the what is the most likely diagnosis for that condition? Okay. What other clinical features before we can look at that? What features I was able to say? What other clinical features would you elicit in such a patient? Buffalo hump. Anything else? Trunk obesity. Okay. Uh huh. Anything else? Okay. Skin. Yes, skin is going to be thinning. All right. Skin will be thinning. Very important. Anything else? Okay. The pendulous abdomen. Pendulous abdomen. Anything else? Okay. Thin limbs. Excellent. Uh huh. Anything else? Irregular menstruation, easy bruisability, so you'll be able to see wounds. Okay, you'll see the purple stripe in the abdomen. So, what is the condition? Cushing's what? Cushing's what? What's the difference between Cushing syndrome and Cushing's disease? Okay, okay, I'm learning. I'm learning. Mm. Okay, okay, I love that. Anything else? Anyone who wants to add something? Okay, so Cushing syndrome, okay, is excessive levels of cortisol in the body. Excessive levels of cortisol. What can cause excessive levels of cortisol? It can include hydrogen, like drugs. Okay, you take drugs which are behaving like cortisol. What else? You can have a cancer. Okay, for example, if someone has what we call the paraneoplastic syndromes, like if someone has got a small cell lung cancer, it can behave like someone has got excess cortisol. Okay, and then besides that, actually that will be the small cell lung cancer is more with a pheochromocytome, and then you are going to have someone can have a cancer of the pituitary. Remember, the pituitary gland is going to release the adrenocorticotropin hormone, which stimulates the adrenal gland to release cortisol. Basically, the adrenal gland has got the cortex and the medulla. The cortex is going to be releasing the catecholamines, epinephrine and norepinephrine. So, if there is excess production of those, that leads to a pheochromocytoma. The adrenal, that's a medulla that I've mentioned. The adrenal cortex has got zona glomerulosa, zona fasciculata, zona reticularis, which will produce salt, sugar, sex in that order. The salt in that case is going to be cortisol. The the salt is aldosterone. The sugar is cortisol. The sex there is actually the androgens. Okay, so it can also be just a cancer of the adrenal gland itself that is overproducing this cortisol. But now, specifically, whatsoever the cause of hypercorticolism, whatsoever is causing that increase in cortisol excessively, we call that as Cushing syndrome. If the specific cause of this Cushing syndrome is a tumor in the adrenal gland, not in the adrenal, but a tumor in the pituitary gland. We call that as Cushing's disease. So Cushing's disease is basically a pituitary producing adenoma. It's really not a malignant cause, it's an adenoma. Okay, that is producing a lot of OSCTH, and that ACTH is stimulating the pituitary gland, the adrenal gland, to release a lot of cortisol. So any cause because of a cancer in the pituitary gland releasing a lot of ACTH, which stimulates the adrenal gland to release a lot of cortisol. That's what we call Cushing's disease. But any other cause will fall under Cushing syndrome. Hope that's okay. Does that make sense? No response? We're okay? Okay, great. The next question is, what are the possible causes of your diagnosis? So we've already mentioned the causes, isn't it? Okay. It can be drugs. It can be iat oh, that's the iatrogenic. It can be a cancer or the pituitary gland. Okay. So that is that. Station 9. The pictures show scans of a 38-year-old with HIV infection. What scan is labeled A and what scan is labeled B? So when you look at the imagings, you have got an X-ray, you have got ultrasound, you have got a CT, you have got MRI. A CT scan is basically an improved form of an X-ray. Okay? It can pick up some things, but they are not as detailed as an MRI. So between the first picture A and the second picture B, which one do you think is picking up much details? Look at A. A, this lesion is more prominent. Okay, this lesion you can see. And you can even see, like, for the brain, you can see the differences between the lining on the outside. There's another lining in black, another lining inside. So you can pick up much more details. You can see even the gyri and the sulci are even more clearer. So you are picking up more details for A. So this is MRI. Second one, that is going to be a CT scan. Okay. So what is obviously seen? So what can you see here? Okay, yes, these are ring enhancing lesions. Enhancing is just meaning that you are able to pick up those lesions. Because there are some causes, there's some infections that can cause lesions in the brain, but you cannot pick them up. So those are non-enhancing. So this is a ring enhancing lesion. That lesion is actually enhancing the ring. Give the most likely diagnosis. What is the most likely diagnosis for a ring enhancing lesion? Toxoplasmosis. Okay, very good. And then differentials. What other causes what other things can cause lesions in the brain? So besides toxo, okay, lymphomas, CNS lymphoma, anything else? Have you heard of a tuberculoma? Or it's the first time? Anyone who has heard of a tuberculoma? Okay, so things like a tuberculoma, cryptococcus, this parasite is also a problem, especially in people with HIV. So cryptococcoma, even gliomas, even it can be a metastatic cancer. There's also what we call progressive multifocal leukoencephalopathy. But take note that this one will actually cause a non-enhancing lesion. So more it's gonna be the end. Okay. And then cerebral toxoplasmosis, which is the commonest cause for a CNS lymphoma. Okay, I mean for a ring enhancing lesion, because this patient actually has got HIV. So there are two things we can think of here. It's either primary CNS lymphoma or cerebral toxo. But toxo is actually very common. in people that have got HIV. So it can actually be our main differential, and then the CNS lymphoma will be a diagnosis. What contraindications do you know in relation to the scan labeled A? So for MRI, you have got some contraindications. You don't do it if someone has got ferromagnetic implants, like those implants that can actually attract iron, like pacemakers, MRI, incompatible prosthetic heart valves, cochlear implants, metallic implants, aneurysm clips. Okay, also severe claustrophobia is a relative contraindication. Pacemakers, we've already mentioned that. Contrast allergy, because you are going to be using contrast in MRI. So if someone is allergic, okay, because you actually inject these. And then MRI has got a table for a specific weight limitation. So that's also a contraindication. The last station says female 45 admitted to emergency unit with a 1 week history, unilateral leg swelling. She agrees to being bedridden for 1 week prior to the admission, denies any history of trauma to the swollen leg. Examination reveals normal vitals, left leg grossly swollen, slightly tender to palpation, with all peripheral pulses palpable. Compression ultrasound scan of the left limb reveals an extensive thrombus in the femoral vein. List 5 differentials for lower limb swelling. Let's start. And the goodness is this question is not even specific to say bilateral or unilateral. So you can mention as much as you can mention. But please know the differentials for a unilateral lower limb swelling and for a bilateral lower limb swelling. So let's mention what can cause a lower limb swelling. Number one. Sorry? Okay. It's bigger says thank you. Anything else? What's a full form? Please don't use the short forms. I don't know them. Okay, Kaposi sarcoma. I remember we were having a round in the word and then someone said HPI. The daughter was, what is HPI? Okay. All right. Uh-huh. Anything else? Okay. Angiomatosis. The effect on the blood vessel. Yeah, that can cause also the swelling. Oh, yeah, we failing to mention the common things. Things like elephantiasis, heart failure. Like we're going to Anjoshani, you guys. You trouble your doctors. Any other? Cellulitis, very good. Cellulitis, deep venous thrombosis. Those are things to think of. Do- Cellulitis, DVT. Don't forget for lower elephantiasis. What causes elephantiasis? Because at this point we are big people, we can't be saying elephantiasis as though it's grade 5. Yeah, okay, Wuncherella bancrofti. It's a filaria worm. Okay, great. Any other? Okay, chronic kidney disease. Now those would be for bilateral limb swelling, liver disease, heart disease, kidney disease, all the so heart failure, chronic liver disease, chronic kidney disease, all those guys can actually cause lower limb swelling. And they name the triad and the 3 components associated with venous thromboembolism. What's a triad? Associated with uh, thrombosis. Yes, please. Virtual triad, excellent. What are the components? Uh, endothelial injury. Number 2, stasis. Okay. Number 3, hypercoagulation. Okay, great. Nice. And then name what is a gold standard investigation for confirming lower limb venous thromboembolism? A Doppler ultrasound. Okay, yeah, Doppler, you need to know that one. So In the past, they used to use what is known as a contrast venography. Okay, historically. You might find it. Maybe they might mark it. But Doppler ultrasound, make sure you know that. Okay. What name two possible complications of lower limb venous thromboembolism? What is the commonest one you should think of? PE, very good. Pulmonary embolism. Now, in internal medicine, you say PE and we'll know that's pulmonary embolism. If you go in obs, that is your next station. If you say PE, with pulmonary embolism is very far away from the mind. PE means preeclampsia in obs and gyne. That's why these abbreviations are not good at all. Okay, so pulmonary embolism. Any other complication for venous thromboembolism? Okay, the clot can dislodge, go into the brain, causing stroke. Okay, though that is gonna be rare because it first has to go to the heart and then go to the brain. It can also end up going or actually to the lungs. That to be the same PE. Okay, but a stroke can happen. That's possible. Okay, post thrombotic syndrome, like there can be chronic pain after thrombi, swelling, recurrent DVT, venous ulcerations. Okay, because there's no blood supply to an area, so there will be ulcers being formed. Okay, and then chronic thromboembolic pulmonary hypertension. The next question, what is the immediate management? So for the immediate management, anticoagulation, you want to stop the clot. All right, bed rest, very important with the elevating of the limb to reduce on the swelling and the pain. Compression stocking. Okay, when you stabilize the limb, you want to compress it to prevent post-thrombotic syndrome. And then pain relief, very important, pain. At least for you, you are not manager, so you just mention the principles of management: anticoagulation, rest, pain. Okay, monitor for complications, identify the risk factor. Just that. So you can see the causes of unilateral limb swelling: DVT, cellulitis, hematoma, ruptured Becker cyst, lymphedema. Okay, so it can be secondary to malignant surgery or infection, venous insufficiency or varicose veins, superficial thrombo phlebitis. Okay, when you are cannulating and then you end up doing wrong things. Compartment syndrome. This is going to be a very important thing to discuss when you go to surgery, your last rotation. And also, it can be a tumor that is compressing the venous or the lymphatic drainage, post thrombotic syndrome. Okay, and then for bilateral congestive heart failure, chronic kidney disease, nephrotic syndrome, chronic liver disease, liver cirrhosis. Okay, medication like calcium channel blockers, steroids, severe anemia, or malnutrition. So all those are possible causes.